to me. At least I have. Are you guys watching some of those MMA fights and other UFC fights where people are being replaced with screens, and the people and the supporters are on the screen, so they are yelling and shouting. Anyways, who is the TA? Faria? Is Faria with us? Can she talk to us?
Yes, good morning, doctor. I'm here.
Very good morning. Now, sometime, Faria, not sometime, you have to keep an eye on the chat as well. So if
Sure,
there,
doctor.
there are any questions, you have to speak. You don't need to wait till the end. Okay?
All right, doctor.
All right. But okay. Shall we start? I think we should start. All right. We should start.
Sure, doctor.
It's 8 o'clock. Yes. Let me change this pointer option to the laser pointer first, and then go. All right. So, what would be our objectives of this coming 50-55 minute session? That at the end you should be able to describe the peripheral course and the distribution of cranial nerve 5th and 7th, which is trigeminal and facial, and name the area the structure supplied by these two nerves. And you should also be able to tell us that how would you test the peripheral supply of these nerves based on their functional components, and also explain the functional deficits and the lesions. So you need to explain why there would be certain lesions and how would you explain those functional deficits based on where the lesion is. Okay, does that make sense? Does that make sense? That this is what the objective of the talk would be. We have 70 participants, and I don't know how many are there in spirit and how many are there in spirit and body. Okay. Now you all know this. Do I need to repeat what it is or what it is not? If you look at the trigeminal nerve and its functional component, you remember midbrain, pons and medulla, as someone said in the last lecture that the neuro is not going to go anywhere, and I told them the neuro will remain with you for the rest of your life. Inshallah, you will have a long life and a good, healthy and happy and prosperous life. You need to know the neuro. Now, two basic components: general somatic afferent and special visceral efferent. Special visceral efferent is this motor nucleus, and this motor component of the nerve is supplying the muscles of mastication. This is in the medulla, which is the principal sensory nucleus or the spinal nucleus, and in the mesencephalic, which is the midbrain part, which is slightly different nucleus. Okay, now this nucleus would have central processes, while the peripheral processes will be bringing the information from the skin of the face, mucous membrane of the oral cavity and the nasal cavity, and it will have a ganglion. So remember that any sensory nerve, if you talk about, there would always be a ganglion. Do you all agree with me or no? Do you agree with me that every sensory nerve should have a ganglion or would have a ganglion?
Doctor, some of the students have said yes.
Some of the students said yes.
One student asked why only sensory nerves have ganglion.
Yeah, it is the beauty of the sensory, because the ganglion we are talking about either the cranial nerve or the spinal nerves. You remember the dorsal root ganglion, which was basically a sensory ganglion. Same are present in these cranial nerves. So if the nerve has any sensory component in it, it will have sensory ganglion. It will have a ganglion, because this ganglion, the cell bodies of these sensory nerves are sitting outside. Hence, they will form a ganglion. A peripheral process will go into the central nervous system, while the central process will go into the central nervous system, while the peripheral process will synapse on the receptors present on the skin or mucous membrane or whatever. Okay. All right. Now, basically, the trigeminal is important sensory nerve, which is supplying our areas of the face and nasal and oral cavity, and also supply the muscle of mastication. Different sensation of the touch, which can be tested by touching these areas. For instance, if you touch the area of the nose or your eyelids or eyebrows, they are all being supplied by the peripheral branches of the trigeminal nerve. While the sensation of the pain, anything which is painful like a pin or something like that, would be stimulate the painful stimuli which are carried inside by these branches. While the motor function is basically masseter, muscles of mastication. So you can see someone chewing, or you close the mouth and ask someone to open it against a resistance, you open it, or you push your angle of the mouth or one or the other side and apply what you call it as resistance, or ask someone to clench the teeth and you feel the temporalis muscle and the masseter muscle. That's how you can test the trigeminal nerve. Now if you look at the trigeminal nerve like this, can you all see me? Yes. Now you remember the mesencephalic and the pontine nucleus and this long nucleus, which is the spinal tract nucleus of the trigeminal nerve, and this small one is the motor nucleus of the trigeminal nerve. So if you look at the different roots of the trigeminal nerve, the bigger root is the sensory root, while the smaller root is the motor root. That makes sense? Does it make sense? Yes, no?
Doctor, some of the students are saying yes.
Okay. Tell me why it doesn't make sense. Why its sensory root is thicker than its motor root. You can talk to us. Labia?
It is Labiba.
It is, sorry, I'm so sorry I couldn't pronounce your name correctly, but would you like to share with us that why the sensory root is thicker and the motor root is thinner?
Because the sensory root provide more precise precise information, like the area of the pain, while the motor is just in general like movement.
True.
You don't need that preciseness.
Yeah. So because the sensory go to the all areas of the face, but the motor only to few muscles of mastication. Hania responded like that. It's very true. So did Al-Anud also replied. Yes, of course, you can see the area of the face and the mucous membrane of the oral and nasal cavity. They're all being supplied by. So there is the bigger component sensory, smaller component of the motor. Now, even if the smaller component of the motor, we do not have a very precise movement of mastication. So we chew, we talk, we yawn, something like that. It's not precise as small as our, you must have learned in your in your MSK module the precision. So it's not very precise. So something that you are chewing, you are not chewing precisely, you are chewing powerfully. So these muscles are supplied by thinner nerves, so that is fine. That's why it's. But if we would have a muscle which is supplying some of the muscle of the face, where you need precise movements, hence that root would be thicker and its sensory root will be then thinner, and which we will see. Okay, beautiful. Now you see the area supplied by the sensory branches of the trigeminal. So we have three branches of the trigeminal, you all know by now: ophthalmic, maxillary and mandibular. And ophthalmic carries information from the skin of the forehead, upper eyelid, ridge of the nose and parts of the nasal mucosa, while the maxillary nerve innervates the skin of the middle area of the face. Where is that middle area of the face? So if you draw the line from the lateral angle of the eye, extended laterally, and from the angle of the mouth, and join these two close to the temporal area. So this area of the face which comes in the middle, which is roughly between the lower eyelid and the upper eyelid, this is the middle area of the face, and this is supplied by maxillary. It includes the side of the nose, lower eyelid and the maxillary teeth, and the part of the nasal mucosa including maxillary sinus and the palate. Remember, the palate, which is hard, and the soft palate are supplied by branches of maxillary, while mandibular division, which is the remaining area down there, is supplied by mandibular, so skin of the lower area of the face and lower teeth, mucosa of the lower lip, cheeks, floor of the mouth, parts of the tongue and parts of the external ear. What about the central part of the nose? Which is what central part of the nose? We will see the central part of the nose, how it is supplied when we will see the ethmoid, thus ophthalmic division through its terminal branches. Then you will see that. All right. Okay. Now, if you guys know this diagram only, I think you will learn somewhere around 75 to 80% of all the distribution of the trigeminal. Okay, over here you can see the functional components, which are spatial visceral efferent and general somatic afferent. Tell me why we call it a spatial visceral efferent. Why we call it a spatial visceral efferent? I asked you because you must have learnt it by now. Sarah said it's parasympathetic. Parasympathetics are, once for all, those are general visceral efferents. Hisham said because they are voluntary. Ghada said because they are test sensation. Special sensation. Muscles derived from brachial arches. Hold on. Muscles derived from brachial arches. Someone say that? Yes, true. Aries mentioned that these are the ones which are supplying the muscles which are derived from the brachial arches. So any structure which is derived from the brachial arches are called as spatial visceral. Okay. Now muscles of the tongue are not being supplied by trigeminal. Remember, muscles of the tongue are supplied by which cranial nerve? Hypoglossal. Beautiful. 12th cranial nerve is responsible for muscles of the tongue, internal and external. All right. Now let's look at the three nuclei, 1, 2, 3, and you can see this orange color part, which is the motor part. Now you can see the thick sensory and a thin motor component, and now it divides into three branches, 1, 2 and 3: ophthalmic, maxillary and mandibular. Now you see ophthalmic continues forward and it passes through. Can you see this oblong black outline there? Can you see that? this is representing which gap in this skull? Beautiful. Alnud said superior orbital. I would complete this name as superior orbital fissure. So this gap is a superior orbital fissure, and ophthalmic nerve passes through that, and it then divides into different branches. Which branches? Nasociliary, frontal, lacrimal. Okay, these are the main branches. Frontal further is divided into supraorbital and the supratrochlear. These are the terminal branches. While this lacrimal nerve will be dividing and joining the other branches will supply the lacrimal gland. That makes sense? So this is, now look at the color coding of this nerve. It is all what type? It is all sensory. But some of the fibers which are running towards the lacrimal gland would be parasympathetic fibers. Those parasympathetic fibers are running along with the nerve. They are not basically are the component of the trigeminal nucleus itself, but some other nerve. Remember that we'll talk about, excellent, Ghada said facial nerve, excellent, Ghada. Facial nerve parasympathetic fibers will run along with this nerve after passing through pterygopalatine ganglion, and it will supply the lacrimal gland. Okay, supply the lacrimal gland. There are other glands, salivary glands supplied by the facial, and hold on, we will learn about these and see the link between the lacrimal gland and submandibular gland. What is the functional relation or mismatch? Okay, now let's look at this second branch, which is the maxillary. Bushra, I said that hold on to this concept that the lacrimal nerve is supplying the lacrimal gland, and Ghada mentioned about that the parasympathetic fibers which are supplying this gland. Remember that glands needs to have parasympathetic innervation for secretion. So these fibers are basically coming from the facial and joining the lacrimal nerve. But we'll also see how the facial nerve is supplying the submandibular gland. So you see both lacrimal and submandibular. One is forming the tears, the other one forming the saliva. So what is the relation? What is the clinical relationship of the two if there is something goes wrong? Okay, that's what will come later. Now mandibular nerve, which foramen is this one? Sorry, maxillary nerve. Which foramen is this one? Rotundum. The word rotundum or round is same thing. Foramen rotundum. Okay, it passes through foramen. But let's look at that. Before that, it gives rise to this meningeal branch. So this meningeal branch will supply the meninges. And remember that the meninges will also have sensory innervation. So if this meningeal branch is supplying the meninges, it will supply the meninges of the middle cranial fossa. Now then it passes through, then it is sitting in this area. What is this area of the skull? What is this area of the skull where you see a ganglion and this terminal branch of the maxillary as infraorbital? Remember we talked about the beautiful, Sarah says it's a pterygopalatine fossa, excellent. The gap between the neurocranium and viscerocranium, that small gap is a pterygopalatine ganglion. Maxillary nerve comes in, and that's where we see a ganglion, pterygopalatine ganglion. And now these are the branches which are coming from the maxillary, like zygomatic, the infraorbital. Now this infraorbital will divide into terminal branches. Through which foramen the infraorbital will appear on the face? Through which foramen? Through which foramen? Infraorbital foramen, correct. So through supraorbital foramen we will have the supraorbital nerve. Through infraorbital foramen with the infraorbital nerve. Okay, and then it will divide into branches to supply the nose and the cheek and the upper part of the upper lip. Okay, these are those alveolar nerves which will supply our upper teeth. Okay, so these are all the upper teeth. Now you can see something which is supplying the upper teeth is also supplying the meninges. Hence, if you have a toothache, you will also have a headache. toothache and headache. Why are they connected with each other? Because of the same nerve supplying these different areas. Simple answer for this is, it is a referred pain. So headache that you feel because of the toothache is basically a referred pain. Now let's look at mandibular nerve. What is this foramen there? Foramen ovale, beautiful, foramen ovale. And you see that the motor nerve is only running with this mandibular nerve. Okay, now this nerve will give rise to the meningeal branch as well. Okay, so foramen rotundum is also supply the mandibular division is also supplying the meninges. But interestingly, this nerve comes out from extracranially and it has to go back inside. So foramen spinosum are accessory meningeal foramina. They are there through which these nerves pass and enter into the cranial cavity again to supply the meninges. Now then, if we look at the muscular branches, which are supplying to the pterygoid, tensor palatini and tensor tympani. So all these orange nerves that you see, these are supplying the muscles of mastication. Then it divides into an anterior division and a posterior division. Now anterior division is mostly muscular branches. Okay, so all the muscles to the temporalis, lateral pterygoid and masseter. Buccal nerve, which is supplying the mucosa of inside of the cheek, is through buccal nerve, which is a sensory nerve. While the posterior division, mostly it is sensory. Remember we talked about the inferior alveolar nerve. We talked about inferior alveolar nerve, and it then supplies the lower teeth through these incisive branches, and the mental nerve. Now mental nerve is a final nerve which emerges out on the surface of the face. So you see that supraorbital, infraorbital, mental, all these foramina, they are lying in one line. The terminal branch of the ophthalmic, supraorbital, the terminal branch of the maxillary, infraorbital, the terminal branch of the mandibular, the mental nerve. So they are all sitting in one line, okay, and they supply the area of the skin. While along with the posterior division, we have a nerve which is supplying the mylohyoid muscle. Okay, supplying the mylohyoid muscle. All right. Anterior and posterior divisions are the branches of the mandibular nerve. Yes, ma'am. You can see that it is one nerve divided into two. Okay. All right. Now these are for you to review. All right. Some of these slides are for you to review. So you have this ophthalmic nerve, which is divided into lacrimal, frontal and nasociliary. Frontal terminal branches will be supratrochlear, supraorbital, but the lacrimal nerve will supply the lacrimal gland, and it will communicate with the zygomatic nerve, which is coming from the maxillary. Now the nasociliary is the one which is dividing into long ciliary nerves, posterior and anterior ethmoid nerves. These are the ones which were supplying the nasal cavity inside. You remember that anterior posterior ethmoidal nerves which are sitting in the roof of the nasal cavity? That's where they supplied. And this is that infratrochlear nerve. Now this infratrochlear nerve will come out and will supply the area of the nose, while this anterior ethmoidal nerve will also come out and will supply the area of the nose that you were earlier talking about. Sarah said, what is the nerve supply? What is the nerve that supplies teeth and meninges? We talked about it. Teeth and meninges. Meninges are supplied by meningeal nerves. So we have a meningeal nerve from maxillary, we have a meningeal nerve from mandibular. They supply the meninges of the anterior cranial fossa and the middle cranial fossa. Okay? While the teeth are supplied by, upper teeth are supplied by branches of the maxillary, while the lower teeth are supplied by branches of the mandibular. You can look at the V2, which is the second division, which is the maxillary. You can see the ganglion, the nerve there. You can see the meningeal branch, which will supply the meninges of the middle cranial fossa, foramen rotundum, and this area is the pterygopalatine ganglion. You can see there PPT, which is the pterygopalatine ganglion, and then you see these branches. Okay, Sarah, Sarah, have a look at these branches, which are alveolar branches. So we have the posterior superior and anterior superior alveolar branches and middle superior alveolar. So we have the upper teeth, and all these are supplying the upper teeth. Also they supply the maxillary sinus. This is that inferior orbital fissure, and the nerve will pass through the inferior orbital fissure and continue as infraorbital nerve through infraorbital foramen, will divide into a labial branch, a nasal branch, and a palpebral branch. Both maxillary and mandibular will supply meninges, correct. Now this is the branch coming from the maxillary, the zygomatic, and the zygomatrico-temporal and zygomatrico-facial will supply the area of the cheekbone. Okay. This is the third branch, which we talked before. The most of it is muscular. A small part is sensory. Okay. Now you can see different muscles which we talked before are supplied by the motor root of the trigeminal. It divides into an anterior posterior division. Anterior division will have the buccal as a sensory. Most other are muscular, while the posterior division mostly they are sensory, except one nerve, which is nerve 2 mylohyoid, which is a motor nerve. Look at this nerve, which is called the lingual nerve. The lingual nerve is bringing sensation from the anterior two-thirds of the tongue. General sensation from anterior two-thirds of the tongue is brought by lingual nerve, while the sensation from the lower teeth by the inferior alveolar. Okay. You remember we talked about the middle meningeal artery wrapped by the auriculotemporal nerve, and this auriculotemporal nerve is supplying the sensory innervation to parotid gland and also innervation to temporomandibular joint. Do you remember we talked about the middle meningeal artery? Okay, yes. Doesn't make sense? We just repeated the whole concept again with the simpler diagrams. Okay? Now, what I want you not to forget at any cost, do not forget at any cost about these reflexes which are mediated by the trigeminal nerve. What are these reflexes? Hisham, it is in the slide. Alright? Auriculotemporal nerve is wrapping around the middle meningeal artery. Corneal, conjunctival, lacrimal, sneezing, and jaw jerk are mesenteric reflex. Do not forget any one of these. So corneal reflex, afferent and efferent limbs. So if you touch anything on the cornea or conjunctiva, you will blink. Which muscle is held is an afferent limb, which is taking the sensation inside, or the ophthalmic branches of the trigeminal and maybe maxillary in case of conjunctival reflex. Efferent limb is bifacial. So muscles of the lids, which are orbicularis oculi, supplied by facial nerve. Remember we talked about the muscles of the face and everything. You need to remember these. Lacrimation. So if you touch the conjunctiva, you will start having more tears. Okay, so ophthalmic nerve is afferent and efferent limb is by the branches of the facial. Remember we talked about the lacrimal gland is supplied by branches from facial. Sneezing. Any irritant that goes into your nasal cavity, which irritates the mucosa of the nasal cavity, you sneeze. Okay, and this sneezing reflex efferent limb is by vagus nerve. Okay, this vagus nerve will constrict the muscles of the smooth muscles of our respiratory system. That's where you constrict and create the pressure, and the different branches which are supplying our larynx. That's where you have the cough and sneezing reflexes. So in this case, this is a sneezing reflex. While jaw jerk, which is kind of a reflex, both afferent and efferent limbs of the jaw reflex are through mandibular nerve. Are you following? Are you guys following me? We have 168 students who have registered, logged in. Now it is same thing. Interestingly, good question. Is a conjunctival reflex, how it is different from lacrimation? It is the same thing. The response is different. In conjunctival, we are looking at the response of blinking, while in lacrimation, we see that tearing, the fluid, the lacrimal fluid formed. Okay, you see that we see two different responses. This is nothing but the same organization. Now what I want you to learn, the peripheral distribution. So where you would see what nerve, right? So you see that terminal branches, supraorbital, supratrochlear, okay, infratrochlear, and these are those branches, the external nasal branches, okay, which are the continuation of your ethmoidal. This is where the infraorbital and the branches of the infraorbital, which are supplying the upper lip and the nose. This is the terminal branch, which is the mental nerve, the terminal branch of the mandibular division. That makes sense? So you need to see what are the branches which are assessed on the face, in the oral cavity and in the nasal cavity. This is what is happening in the nasal cavity. So if you draw a diagonal line, can you see the red line there? The area anterior to that is supplied by the ophthalmic division through anterior ethmoidal nerve, which is dividing into nasal branches, while the posterior part is supplied by the maxillary nerve through its alveolar branches. Okay, so you see the posterior area is supplied by V2, while the anterior area is supplied by V1. Same is on the septum. So if you look at the septum, draw a line and divide into these two areas, you will see that the nasopalatine was the branch coming from the V2, and this is the anterior ethmoidal nerve. Remember the anterior ethmoidal nerve? Somebody was asking about what the rest of the nose. You see this branch which is going to the dorsum of the nose. This is the external nasal branch, which is coming from the anterior ethmoidal nerve, and it is supplying the central part of the nose, close to the root of the nose. Remember we looked at these diagrams before. In the superficial dissection of the infratemporal fossa, what you see these different branches of the mandibular nerve. That's where the mandibular nerve that you can see in the deep dissection, and these branches which are supplying the different structures. Most of these are muscular. This is the inferior alveolar, and this is that lingual nerve, which is going to supply the anterior tooth of the tongue. This is that pterygopalatine fissure, and you see this maxillary nerve sitting inside, and this is this branch which is going to the nasal cavity. Okay. Now, how would you clinically examine the trigeminal nerve? You will look for the sensation, pain, thermal, and other sensations in the area supplied by the nasal cavity, supplied by the trigeminal nerve, and also reflexes, different reflexes. So corneal, conjunctival, jerk, jaw jerk reflex, and the muscles of mastication. So you look for you palpate them, you look for the movement, you push the jaw against resistance. That's how you clinically assess the trigeminal, different branches of the trigeminal nerve. Okay, does it make sense? Okay. This slide I will not read, but I would want you to look at and read at your own time. How would you evaluate the sensory, motor, and reflex components of the trigeminal nerve? And you will see that you can then differentiate between the lesions of the distal to the trigeminal ganglion and at or proximal to the ganglion. Okay, same will be the motor. So it's if there is a motor damage, it will be an ipsilateral damage. Now, interestingly, when you are evaluating the sensory areas, the damage to the one or the other nerve will not cause a complete loss. It will most likely alter the sensation. So there will be reduced sensation. hyperesthesia, altered sensation, dysesthesia, abnormal sensation, paresthesia, or maybe pain in affected divisions. But complete sensory loss is not there in many cases. Okay, while reflexes, corneal and the jaw jerk reflex, so we are looking for the blink reflex. Okay, we are looking for the eyes to blink and also become watery. So blink is the blink reflex or corneal conjunctival reflex, while lacrimation is the tear, formation of the tears. Jaw jerk reflex, tap it, and you are basically looking for temporalis and masseter muscle reflexes. Now, if there are lesions in these branches, it's the same thing. Corneal reflex, depending on where are you touching, the corneal and the conjunctival reflex. Okay, the corneal and conjunctival reflex, that's where slight difference in the area which has been touched. Otherwise, it's the same thing. Now, look at what would be the effects of the lesions if there is ophthalmic, maxillary, or mandibular division affected. So you see that paresthesia over the area supplied, loss of corneal reflex, which is the blink reflex. In case of maxillary damage, loss of sneeze reflex. In case of mandibular, paralysis of the muscle of mastication and loss of jaw jerk reflex. Now you see everything else it says paresthesia there, not anesthesia. Paresthesia means changes in, because there are a lot of overlap of these different areas. So it's not a sharp line. Okay, it's not a sharp line that you can draw. Now something which is important to know, that some features which are important. For instance, the position of the chin is important in our face. If we have difference in the muscles of mastication which are keeping the jaw, the lower jaw in place and the chin in place because of the tone, you know the tone of the right and the left side of the body is helping us to stand erect normally. If one or the other side will be weakened, we will trip on one or the other side. Just to maintain the position of the chin in the middle, both the right and the left pterygoid muscles especially are keeping the chin in its position. Okay, corneal reflex, if it is lost, what will happen? If we are not blinking, what will happen? Our eyes will get dry, there will be ulceration, could be blindness. Headache, because of any problem in the distribution of the trigeminal nerve. Headache is nothing but a referred pain that we feel. Okay, so toothache, headache. Okay, any problem of the nose will give us a headache. Maxillary sinus blocked, headache. Frontal sinus blocked, headache. Why? Because it's the same nerve which is supplying these areas. Trigeminal neuralgia is the irritation of any branch of the trigeminal nerve which is causing severe pain. Okay, let's look at this diagram. Tell me, what is this woman doing? What is this woman doing here? What is this action? Protrusion. Protrusion is bringing the jaw forward. What is the abnormality in this case? In this woman, what is the abnormality? The mandibular nerve is affected, the lateral pterygoid is affected, hence you see the position of the chin is deviated. Which side is normal? The left or the right side? Which side is normal? Right or the left? Left side is paralyzed, right side is normal. Left side is paralyzed because you see that the left side is paralyzed, right side is normal. To keep this position, it pushes the chin on the affected side. Otherwise, if both would have been normal, pushing each other, the chin would have been in the midline. Okay, so paralysis is on the left side. Now the trigeminal neuralgia most of the time is idiopathic, people suggest that there is a compression of the nerve roots by the vessels. Okay, there are other reasons of the neuralgia. Different disease processes can affect it. The clinical feature of the trigeminal neuralgia is severe pain, and this will lead to the spasm of the facial muscle by touching some of the areas of the face which are called trigger zones. So some areas, if people touch those areas, there will be severe pain and there will be the muscle which will go in a spasm. Now this can happen frequently, but after these episodes there could be long period, like after months or years, but it can come back again. Okay, so these are some of the areas on the face when you touch, they can give rise to the pain. Facial nerve, by now you all would be expert on the facial nerve. These are the different components of the facial nerve, okay, which are supplying different areas. Muscle of the face, remember SEV, SVE, which is branchial arches. So muscle of the facial expression. This is going to the submandibular and sublingual and the lacrimal gland. All these are coming from superior salivatory nucleus. So we have a branch, chorda tympani, a greater petrosal. They will supply the lacrimal and submandibular sublingual glands. While this ganglion, which is the geniculate ganglion, is bringing information from the tongue. Remember that wherever there is sensation, there has to be a ganglion. So geniculate ganglion is there. Anterior two-third spatial sensation. From the skin of the ear, general sensation. So you remember the general sensation is going to the spinal nucleus of the trigeminal, while this is the gustatory nucleus, which is the spatial visceral afferent nucleus. I want you to pay attention to this foramen where we have the vestibulocochlear nerve and the facial nerve. Then the facial nerve passes through a bony canal which is basically running in the temporal bone. So different components of the nerve are passing and sitting in the different parts of the temporal bone. So through this internal auditory meatus, it runs inside, so which is the meatal part. This is the area where it is bent like a knee, that's why I call it this area the geniculate ganglion. Then it is the tympanic, which is the horizontal part. Then it is the vertical part, which is the mastoid part. Okay, look at this nerve. Look at this nerve, which is nerve to Stapedius, and this nerve, which is the chorda tympani. These both nerves come from the facial nerve before it passes through the stylomastoid foramen. Remember that. So these both nerves come from the facial nerve before it passes through stylomastoid foramen. Why I am emphasizing it? Because if there are problems before styloid or after styloid, it will be different. So you can see it here, the course of the facial nerve. That's where the geniculate ganglion. That's where the nerve which is going to the lacrimal gland. This is where the pterygopalatine ganglion sitting in the pterygopalatine fossa. This is the facial canal, okay, and this is the stylomastoid foramen, and the nerve is coming out from there. Okay, now this nerve which is coming from the facial nerve arises before it passes through stylomastoid foramen, and this is the chorda tympani. This chorda tympani is carrying the spatial fibers from the tongue and parasympathetic fibers to the submandibular ganglion. That makes sense? Now you see that the facial is now supplying lacrimal gland and also submandibular gland. Okay? On the surface of the face, this is what the distribution of the facial nerve is. So you all know temporal, zygomatic, buccal, marginal mandibular and cervical branches, which have been numbered here. And this is the nerve which is supplying posteriorly, which is the posterior auricular. Okay, now you see these branches, they supply not only the muscles of the face, but this occipitofrontalis muscle and the muscles of the auricle. We cannot move our ears, but animals can do. Can any one of you move his or her ears? Can any one of you move? You can wiggle your right ear. Okay, that's good. That's good. All right. Is that making sense? Yes, no? This is mostly the repetition of something that you have learned before. This is how it is. These are the different nuclei related to the facial nerve. This is the part which we call the facial nerve. Now you see that motor root and the sensory root. Which root would be thinner in case of the facial nerve? A motor or the sensory? Sensory, because it has only little area to supply, area of the ear and the tongue. So sensory root would be smaller. Okay. Now see the genicular ganglion there, and this is that parasympathetic nerve, greater petrosal, and this is pterygopalatine ganglion and lacrimal gland. Okay. While from the superior salivatory nucleus, the fibers will come, pass through the chorda tympani, run along with the lingual nerve and the synapse into the submandibular ganglion and supply the submandibular and sublingual salivary glands. So you see the facial is taking care of the lacrimal gland and these. What if there is a mixing of these fibers there? What if there is a mixing of these parasympathetic fiber? If there is a crossover because of the damage to the nerve at this point, what would happen when you start eating? What will happen when you start eating? You start crying. Beautiful. You start crying as well. Why? Because saliva, which is stimulated through that, will also cause your lacrimal gland to be stimulated, as if you are having the crocodile tears. Okay. So it's not. You remember that we talked about auriculotemporal nerve, and the branches which are supplying the skin, the great auricular nerve. If there is a damage and if they swap, they will supply the skin of the parotid region. So salivation will also cause flushing and the sweating there. Same thing, if there is a crossover of these fibers to the lacrimal gland, while you are making saliva, you will start making lacrimal gland as well. So what time? Obviously at the time of eating. So you will be crying as crocodile tears. Now most of the muscles of the face, you see, which are supplied by the motor nucleus, okay, they are coming out from the stylomastoid foramen, after the stylomastoid foramen. Okay, chorda tympani comes out before the stylomastoid foramen. That makes sense? Now how would you assess facial nerve? Same thing, motor and sensory. So what would be the motor action of the sensory? You know what is the big thing about the facial nerve? It is maintaining the symmetry of the face and closing of these two spaces, the eyes and our oral cavity. So these two muscles, orbicularis oculi and orbicularis oris, and maintaining the balance across either side of the face. Any disbalance of the muscles will change the shape. Hence, looking at carefully will help you. Sensation, tongue, anterior two-thirds of the tongue are the ones. So you see that it's, once again, it will not be complete loss if there is a damage, but there will be altered sensations. Now, facial nerve paralysis, if you see what are the causes, based on anatomy, it could be intracranial, cranial, or extracranial. Intracranial could be tumors, surgical trauma. Cranial, you see it was passing through the middle ear, so any problem of the middle ear, infection of the trauma can compress on the facial nerve. Same is with the parotid tumor. Remember we talked about the parotid tumors and the facial nerve sitting there, it will compress on that. Now according to the causes, It could be a problem at the time of the birth trauma, head injuries, parotid and mastoid surgeries, and inflammatory process, otitis media, necrotizing otitis externa, herpes, different neoplasias, neurological condition like Guillain-Barré syndrome, multiple sclerosis, but the most common is Bell's palsy, which is idiopathic. We do not know exactly the whole underlying pathophysiology of it. Okay? Now, if I ask you that this is the motor and this is the sensory root of the facial nerve, this is the geniculate ganglion, and it is passing through the temporal bone, and that's where it gives rise to the nerve, which is nerve to stapedius. Remember, we talked about nerves which are coming out before the stylomastoid foramen. We talked about chorda tympani. The other nerve is the nerve to stapedius. Now, stapedius is the small muscle of the middle ear, which is dampening the sound. So, bingo, large sound that you hear, the next time the sound would be damped because the muscle will be pulled. So, our eardrums will be stiff. Okay? Now, what would happen if the nerve is damaged at these four sites? What would happen if the nerve is damaged just at the stylomastoid foramen? Bell's palsy, which is loss of motor function of all the facial muscle of facial expression. It will deviate the mouth towards the normal side. Remember that? Both right and the left are making a smile normally. So if one is weaker, the mouth will go towards the normal side. The abnormal side is weaker, so that it will be pulled by the normal side. Okay? If it is at the site B, then what will happen? All these features along with the chorda tympani. If the chorda tympani is affected, what will happen to the salivation and sensation to the tongue? These will be affected, so they will be reduced. Okay? Is it making sense? Ghada says hyperacusis. Well, we'll come to the hyperacusis. Beautiful. This is the right word, hyperacusis. Now, if the damage is at the point C, so this muscle will be paralyzed. So sound waves, even of the normal intensity, when they strike, you will hear it louder. Hyperacusis, because you cannot damp the sound. Hyperacusis. That's why these people will be afraid of sound. Phonophobia. The word is phonophobia. Okay? Sensitivity, increased sensitivity to the sound. Excellent. Now, if the nerve is damaged at the geniculate ganglion itself, then what will happen? Everything down there will be affected, including the lacrimation to the nerve to stapedius will be affected, chorda tympani, all. So you see, everything will be affected. So you see that more closer to the brain you go, the effect will be bigger. More closer to the muscles and the structure that you go, the effect will be smaller. By now, you all know the facial nuclei. They are divided in upper and the lower parts. Now the face, remember that we talked about the face. The upper part of the face is bilaterally supplied by right and the left cortex, while the lower part of the face is supplied by the same side of the nucleus. So the lower motor nucleus is of the same side, while the upper motor nucleus, upper motor neuron are from the opposite side. This is something that you must have learnt in neuro, and I expect you to know this. Even in your dreams, you should know this. Now, if there is a damage, upper motor neuron lesion, only the contralateral lower part of the face will be affected. But if it is a lower motor neuron lesion or the nuclear lesion, then the entire half of the same side of the face will be affected. Does that make sense? Does it make sense? You should have known this. This is just a repetition. Okay? This is how you will test the peripheral lesion and the central lesion. The peripheral lesion will only affect, the central lesion will only affect the lower part, while the upper part of the face will be normal. That's why you see that you will be able to close your eyes. But in case of the peripheral lesion, which is in case of the nerve itself, the closing of eye will be affected. Okay, that's how you will differentiate between the peripheral and, because the upper part of the face is bilaterally innervated. Bell's palsy, commonest cause is the inflammation of the facial nerve at geniculate ganglion, okay, which leads to compression and ischemia and maybe demyelination. Bell's palsy is defined as idiopathic, most of the time it is, and inflammatory causes in the facial nerve. Remember, we talked about these different sites where the nerve could be damaged. Ramsay-Hunt syndrome is affecting the geniculate ganglion due to herpes zoster infection. Now you can see that what would be the sign and symptoms. Vesicles, herpes vesicles in the auricle that you can see. Hyperacusis. Why hyperacusis? If this ganglion is affected there, this nerve will be affected. Remember, we talked about the crocodile tears. So lesion proximal to the geniculate ganglion, and there is a crossover of the parasympathetic fibers going to the lacrimal and sublingual and submandibular gland. Is it making sense? Ramsay-Hunt syndrome, these features, and crocodile tear syndrome. You tell me now, which picture, 1 or 2, and which side, left or right, is affected? Radha says 1R. Sara is saying that, so side C, as you go up, hyperacusis. Let me go up. At this point there will be hyperacusis, yes, and it would affect the salivation, not the lacrimation. Okay. Obviously, it's going to affect the taste as well. Any other thoughts? 1R. 1R. Okay, 1R. So what happened after some time? What happened then? This is an old man who had problem of the facial nerve, which were then treated surgically, and you can see that regrowth of the nerve fibers will help regain the power. Okay. This is the diagram that I will leave with you. If there are problems at site A, B, C, and D, what would be the functional deficits? What would be the functional deficit? You have to send me your answers onto this email. I will reply back to you with the corrections. Okay? That makes sense? Do you all agree that I should send it to you? Or you should look at this diagram and tell me what will happen if there is a damage at A, B, C, and D. Okay? If you have any questions, ask me now or whenever. Any question that you have. So what is the most important? See the distribution of the trigeminal, see the distribution of the facial, the area supplied, skin, mucus or muscle. How would you test those? By touching. Okay? How would you test the muscle? By action against the resistance. Okay? What is the main muscle weakness? If one side is affected, usually the normal side would make the things look asymmetrical. If the left side is weaker, the right side will pull the structure towards its side. Okay? So this is how you differentiate. So make sure that you understand the size of the lesion, what would be the effects of those lesions, and how would you determine the size of the lesion. Okay, I stop here. Is Bell's palsy ipsilateral? Usually it is ipsilateral. Yes, it is ipsilateral. When would I kindly upload the lecture? After my lecture. Anything else? Tasneem, did I answer your question? Thank you. Is Faria with us? Faria, are you there?
Yes, doctor.
We need to close this meeting, or do you want me to just leave it, or will continue?
Yes, doctor. As you leave, it'll close.
The other question from Muhammad is, Doctor, what about the optic ganglion? Optic ganglion, remember we talked about the optic ganglion when we were talking about the parotid gland, remember? So the auriculotemporal nerve, and then the parasympathetic were coming from the glossopharyngeal, and that's where the postganglionic fibers were running along with auriculotemporal nerve to supply the parotid gland. So optic ganglion is functionally related to the parotid. Pterygopalatine ganglion is related to lacrimal. Sublingual is related to the sublingual and submandibular glands. Ciliary ganglion is another ganglion which is sitting in our orbital cavity, that is related to the smooth muscles of the pupil. Okay, smooth muscle of the pupil, and that is functionally related to which cranial nerve? Third, oculomotor nerve. Excellent. Does the facial nerve take its sensory component from the optic ganglion? Sensory component from the optic ganglion? No. Remember these. Optic, pterygopalatine, submandibular, or ciliary ganglion. They are not sensory ganglion. They are parasympathetic ganglions. The sensory fibers just pass through. Sensory fibers will just run through. They will not synapse there. They just run through those. Okay? Shall I stop here?
Thank you, doctor.
Thank you very much.